only and only to disseminate the knowledge. No one is bothered about their publicity or promotions, including Jyotika Desai, Sundari Madam, Chenmay Rath, Raju Reddy, and even our own Srimati. I am really proud of my team. With this, I close my talk. Thank you, everybody. Please enjoy this session. Thank you.
Thank you very much, sir. Thank you. So as Sir mentioned, this is the first webinar of the Clinical Research Committee. So I thank Sir for giving the platform and Jyotika ma'am for guiding us throughout at every step. So first, I would like to introduce the judges and the speakers, as Sir said very briefly. And the rules are very clear. 12 minutes for the presentation. The 4 speakers will be doing the talks. Then later on, 3 minutes for question and answers by the judges. And of course, the speakers will be judged on their timekeeping, their their ability to answer the questions, synthesis of evidence, etc. So first, I will invite the judges, Dr. Jyotika ma'am, who's the advisor now for KSOGA. She's a senior consultant at PR Desai Hospital, past president of BSOG, and she's got a Lifetime Achievement Award, and she's a real perfectionist. Sundari ma'am, she's an honorary professor currently at Madhusudan Sai Institute, was previously at MS Ramana, great teacher, and we are really privileged to have you, ma'am. And of course, as Sir said, Dr. Chinmayi Ratha from Telangana. So thank you, Dr. Chinmayi, for joining us. She's the chairperson of the Foxy Perinatology Committee and a great clinician, and she runs the Resolution Center for Fetal Medicine. And to introduce the speakers, as Sir said, Dr. Lakshmi from Mandya. She's a consultant OBG at Sri Dayananda Nursing Home, Malavalli. And Dr. Purnima, she's a MRCOG, and she's currently working at Bellary Health City. Then we have Dr. Joylyn D. Almeida, Associate Professor from Father Muller Medical College. She has got lots of credits and publications to her credit. So welcome, Dr. Joylyn. And Dr. Rashmi Suranganvi, she is currently working at Dr. Suranganvi Srimati Bharati Devi Memorial Hospital, and she's got lots of fellowships and awards, and she's got lots of publications as well. So with this, I would like to open it up to the judges and the speakers. Ma'am, you want to say anything before we invite the first speaker?
I would just like to tell them to be relaxed. It's not like an exam. So kindly take it easy. And I would like to request you to confine yourselves to 12 minutes, because if you overshoot your time, then the question time will be less and the marks awarded also may come down. So kindly stick to your time. Okay?
I'll give a warning at 11 minutes.
And take it easy. Don't get tense. We are not examiners here. Okay?
Thank you, ma'am. So first with this, I would like to invite Dr. Lakshmi to start presentation.
Hello, ma'am. Good evening, everyone. I would like to share my screen.
Yeah. I'll give a warning at the end of 11 minutes and 12 minutes, please.
Yes, ma'am. Can you see my screen, ma'am?
No, not yet.
That's where we lose our time usually, right?
Yeah.
Anyway, you don't panic. It's not your time, okay?
I request others also to keep their presentations open and ready. So, Lakshmi, if you have got it open, Dr. Lakshmi, just click on
yes, ma'am.
Click on the share and click on that.
Yeah,
perfect.
Coming.
Full screen.
Ma'am, can you see my screen, ma'am?
Yeah, but can you make it as a slideshow?
Yes, ma'am. I'll just.
We can't see the PPT still.
I'll just go to the next slide.
1 second.
Starting, is it? No, the next one, yeah. Yeah, perfect. Slideshow.
Full screen, Lakshmi.
Yes, ma'am.
Yeah.
Ma'am, can you see?
Yeah,
yes,
we can start.
All good.
Yes, ma'am. Right. Good evening, everyone. Now I would like to present on aneuploidy. And ma'am, can you see my screen?
It went off.
No. I think you should keep that screen open. Go to that screen.
Yes, ma'am.
Keep that screen open. Yeah, just keep the screen open and keep moving it, because once you move it, it'll be a problem.
You're going to the next slide?
Ma'am, share your screen.
I request the other speakers to send their PPTs to Arun so that he can project it.
Yeah, Arun or even me, I can also do it, not a problem.
I know. Yeah, she
I've shared it.
better
Shared it to me, Dr. Lakshmi?
No, first
Yes,
thing
ma'am.
you share, Lakshmi, you share your PPT and then open, ma'am.
Yes, ma'am.
Slides will start moving. Okay, you first share it. Was she enabled to share?
Yeah.
Make it a slideshow now.
Ma'am, can you see, ma'am?
Yeah.
Keep moving
Yes,
the
ma'am.
slides. Just move the slides. We'll just see whether it's
Yes,
moving.
ma'am.
Slides
Yeah.
are moving. Yeah, you can start.
Yes, yes, ma'am. Aneuploidy, an abnormality in number of chromosomes in a cell due to loss of duplications. We humans have 23 pairs of chromosomes. One extra chromosome or one deleted chromosome can cause aneuploidies. Not only the number, even the deletion of a tail of chromosome or an addition of a tail of chromosome can be called as aneuploidy. What are the causes? Of course, everybody knows errors in meiotic divisions, increased risk with maternal age, as nowadays the age of marriage has been increased or it has been postponed by some 3-4 years. We may encounter many number of aneuploidies. That is the reason why we are pressing on aneuploidies. Increases even with the radiational effects, most probably with the mobile radiation effects. Aneuploidy, why we need to screen in pregnancy? Because the chances of miscarriage are more. Coming to birth defects, there may be birth defects. When the baby is born, we may not be able to cope up with the lifestyle of the babies. There may be developmental delay. See, it's not that aneuploidy causes all the structural anomalies. There may be some other functional deformities which we need to address. So, how do we diagnose aneuploidy prenatally, which is very important to give a healthy baby to a mother? What are the a priori risks? When a pregnant lady comes to our OPD, we are priorly, as soon as we see her, it's not like we are giving them the a priori risk. What is the a priori risk? When the maternal age is above 35, we label it as elderly primary, which is a risk factor. So age matters more. And the average age of maternal age is a count for priori risk. Then the history. What are the histories which add on to the risk of aneuploidy? One is the prior history of any aneuploidies in the family, or the prior history of miscarriages, or the history of IVF itself is a risk factor. Coming to the gestational age, what is the gestational age considered as a priori risk? Because see, once a mother has conceived, the age what she calls up, and like 10 weeks of gestation, she has the a priori risk lesser than what she has in 8 weeks. Because aneuploidy, in case of aneuploidy, there is natural or nature which takes case and reduces the baby. That means there may be a miscarriage or a blighted ovum, which will reduce the risk of with the gestational age. That is, the a priori risk at 10 weeks is more than the age at 20 weeks or 40 weeks. So that means to say, we need to screen as early as possible. Which is the best window to screen for a pregnant lady? First trimester screening, that is the most important point where we can diagnose aneuploidies. What are the methods we are going to use in first trimester screening? The one major and gold standard is the combined screening, which we'll do from 11 to 13 plus 6 weeks. And then comes the, what are the markers? Combined screening, it is like the ultrasound markers, biochemical markers. What are those to be done? First is the scan. As we have already taken the a priori risk, then comes the scanning. Scanning is the major NT scan, first trimester scan, or the NT scan. Why is it named NT scan? Nuchal thickness is the major factor which tells us the whole body mechanism or the biochemical methods going on, functionality of the baby is depicted by the NT. Next, who has to perform this NT scan? See, when everybody can do, as we know, ultrasound can be done by gynecologist, as obstetrician, ultrasound can be done by fetal medicine specialist, ultrasound can be done by radiologist. So, well-trained fetal medicine, he'll be a better person to do a NT scan. What are the structures we are going to see in NT scan? See, in NT scan, not only the NT, the major soft markers are minor markers, but why do I press it as major? Because those are the things which are going to tell us about the aneuploidy. NT is a function of gestational age. It doesn't stick on to one NT. See, at 10 weeks, at 11 weeks, we may say 1 mm is the normal. But at any given time of gestational age, more than 3 mm is considered as an abnormal. Usually 5 to 95th centile of NT is considered to be normal, and we need to check with the NT scan with the algorithms provided by Fetal Medicine Foundation or KSOGA or some methods which are soft things available with us. We have the charts which can depict what is it. Now, I want to stress on NT scan, which has markers. Isolated markers are more important because each and every isolated marker carries the risk factor with it. What are the risk soft markers which can identify the aneuploidy? One is unossified or hypoplastic nasal bone, increased nuchal thickness, ARSA, ventriculomegaly, echogenic bowel, mild hydronephrosis, intracardiac echogenic foci, short humerus, short femur, or those things which depict us about the aneuploidy features. So, if these things are present, we need to take it whether it is isolated or it is combined with other. See, when an increased NT is there, when an echogenic bowel is there, I am supposed to add up the likelihood ratio and then calculate the risk factor. So, if one isolated marker is there, then I am not at a very early conclusion that this is it. So, I need to calculate the risk factor. What are next? This is the NT scan where I screen sagittally from one side to another, where I look onto the limbs from starting from the head. I go up till the toe coronally and sagittally, and I need to look for all the markers and the development of the baby. When NT is calculated, it is adjusted according to the CRL, that is crown rump length. When the crown rump length is this much, the NT should be this much. This is the table what we get in fetal medicine, and we need to check along with that. Coming to markers. Next, this is the scan. Next, coming to biochemical markers. What are the biochemical markers we are going to check? We are going to check for beta HCG, alpha fetoprotein, PAPP, estradiol, unconjugated estradiol. But in first trimester, we have only two markers, beta HCG and PAPP, which majorly show us where it is. When it comes to trisomy, beta HCG and PAPP are totally raised. Both beta HCG and PAPP are raised, and in case of trisomy, so we need to calculate according to MOPS. As an obstetrician, we get a report. We just do get an NT scan and we send for biochemical analysis, where we need to get into these. We get the reports. We need to counsel the patient regarding the reports. How do we counsel? When beta HCG is given, we need to check for multiples of median, that is MOMs. When we come to know about the MOMs, we know the risk factor. What is the risk factor in such reports? When a trisomy is less than 1:250, we consider it as positive results. So we need to know about what are the risk factors. When we get a report, there may be a high risk regarding NT. It shows this increased NT is the risk factor. When beta HCG is raised, it is mentioned that it is due to biochemical marker. We need to check whether this biochemical marker is included for aneuploidy or some other factor. Maybe placental factor is adding up on to beta HCG or PAPP. Whatever it is there, we need to see that the risk factor is for what, whether it is for NT or biochemical marker. When we get a first trimester screening, we need to calculate, we need to see whether it is low risk or high risk. When it comes to low risk, we need to see that after low risk, whether we need to counsel them for NIPS or whether we need to go for CVS or amniocentesis. When it is high risk, we directly advise them, counsel them rather than advising them. We need to counsel each and every patient, and we need to give them the evidence to say that it can be diagnosed with chorionic villus sampling or amniocentesis. Next, coming, what are the tests what we do? See, when high risk comes, we need to tell them combined risk is so much. Then what else we can do? Next, second trimester, when we go with the other quad test with the scan. Coming to integrated, we take a first trimester scan, second trimester scan, and a quad test. When it comes to low risk, we go with the stepwise sequential screening, where we need to go to first trimester when it is high, low, and then go to the major important topic of today is NIPS, non-invasive prenatal checking screening, where all the patients should be given this option, so that it is a non-invasive procedure. Just because of financial constraints, we are not supposed to keep it up. We need to give them the offer. It is left to the parents what they are going to do. What is NIPS? Non-invasive prenatal checking, where maternal blood is drawn and seen about the fetal blood cells. Fetal free DNA is available for knowing the chromosomes in fetus. So where we can do is more than 10 weeks, and what reports are available where the fetal fraction is more than 4%. Always when NIPS is come, we need to check for these things. There is an extended NIPT where it includes not only the structural these things, chromosomal aneuploidies, it also goes through translocation and dysfunctions. What are the restrictions for NIPT? Restrictions for NIPT is structural abnormalities, increased NT. When there is structural abnormality in the baby, what is the use in going for NIPS? You have a strict direct action you can take up. So inborn errors, when there is a placental motility. Yes, ma'am.
Yeah.
So confirmatory is mandatory. Not only the first trimester screening, of course, in first trimester screening, if we don't have anything, we have to go in the second trimester and see what we get. We get genetic sonogram, quad test, integrated screening, and the confirmatory, 100% confirmatory should be done with amniocentesis. What are the major types of anomaly? Aneuploidies, trisomy, Klinefelter, Turner's, and extended like Robertson-Noon syndrome. All those things can be diagnosed. Definitive test is ascertained to fetal chromosomal abnormality is only by invasive testing, that is chorionic villus sampling or amniocentesis. These are the procedures, but confirmatory tests is FISH, QFPCR culture, and microarrays exon sequencing. So now coming to what is beyond. Beyond is, first we have to give early diagnosis to the patients, counsel them, confirmatory tests, you give them the options of confirmatory tests, then management. The management nowadays, we have
12 minutes.
We have AI-based ultrasound machine to detect. Thank you.
Thank you, Dr. Lakshmi.
Thank you, ma'am.
Thank you.
That was a very comprehensive presentation, Lakshmi. Very good.
Thank you, ma'am.
Coming to you didn't mention an intermediate.
Questions we said in the end, no, ma'am.
Now only.
Last month, 3 minutes, 75.
Okay. So, Lakshmi, you did not mention the intermediate risk. You mentioned
Yes,
the high risk and the low risk.
yes, ma'am.
And the low risk is where you don't do anything. We know that, don't you? Okay.
Yes, ma'am.
Can you tell me, supposing one of your patients comes with the NT of 3.5 millimeters, scan done somewhere, how will you manage? Quickly. 1, 2, 3.
Again, you rescan. First, check with the algorithms whether it goes with that or not. And only increased NT may be suggestive of these things, but you look for other things and again go for biochemical if it depends on the gestational age and take a NIPS.
When you said other things, what are you going to look for? Which can give rise to increased NT?
Which
in the
aneuploid. Structural anomalies, structural, or see when it is RH negative, those also can cause sensitivity in 8 weeks or something.
No, we are talking about cardiac abnormalities.
Yes, cardiac abnormalities.
Common cause of increased NT apart from aneuploidy. Okay. So you find out first whether it's a certified FMF person who's done the scan. Next, what will you do?
Ma'am, if NT is increased, then look for structural abnormalities. If everything is fine, you just follow it up or give them the option of NIPS first and then the confirmatory test if any aneuploidies are there by CVS or amniocentesis, depending on the gestational age. It is depending on the counseling, how you counsel and how the patients respond. It's not the call of the obstetrician, it's the call of the patient, how you counsel and how they get back to you. Like you give them the option and take up the calls.
50 to 60% of 3.5 millimeters, which is the 99th percentile.
95th. Ma'am, both the ISOG and they have a discrepancy between 3.5 and 3. But still, if it is in the second trimester, we just give them the counseling.
If I think Dr. Sundari, would you like to ask? There are some points which we'll raise later on. Dr. Sundari? Sundari, unmute yourself and ask the question.
Am I audible?
Yes, ma'am.
You are audible, but you're not seen.
Lakshmi, it was
Yes,
a good
ma'am.
presentation, ma'am. But
Thank you.
see, is there a first time step quad test?
Yes, ma'am. It
What
can
are
be
the
done, but
markers? What are the markers in that? Suppose this patient has come, as Dr. Jyotika said, 3.5 NT. Could you do the quad test here? And what are the
Yes, ma'am.
biomarkers in that quad test, first trimester?
Unconjugated estradiol, alpha fetoprotein, and estradiol.
No, first trimester quad is not that. PAP-A, beta HCG, PIGF, and alpha fetoprotein.
PLGF, yes.
That has got sensitivity of 94%. Without, instead of doing double marker, you can do quad test. Okay. Okay. Thank you.
Thank you.
Chinmay asks.
Yeah, I would like a very nice presentation, Dr. Lakshmi. Just one question. When you started, you said the risk of aneuploidies increases with radiation. And when you gave the background of increased maternity, would you hold that to evidence? And if so, why would you think radiation would increase aneuploidy?
Ma'am, actually, in one of the literature, they had given because of IVF, the radiation effects that has increased the risk of aneuploidy. But I really don't know.
Because when we say radiation, and especially when you use the word like mobile phones, it's going to lead to a lot of panic the moment you say that.
They're given that.
Pregnant woman seeking fertility advice gets in touch with her doctor through the mobile phone. So how will that happen? So I don't think there's a lot of evidence there. Radiation is known to be associated with mutations rather than aneuploidy per se.
Yes.
But that's okay. So no, very interesting presentation and all the best.
Thank you, ma'am. Thank you.
You are the opening batsman of this competitive series.
Yeah. Well done, Lakshmi.
Thank you, sir. Thank
First
you.
batsman of the program.
That's opening batswoman.
Yes. Well done, well done.
Purnima,
Thank you.
Dr. Purnima, you ready with the slides?
Yes, ma'am.
Yeah. Got the PPT there?
Oh, yes, ma'am. 1 minute. One minute, ma'am.
While she is loading, Lakshmi, with the
Yes, ma'am.
just we are not going to consider this, but with the NT of 3.5 millimeters, which is the 99th percentile,
Yes, ma'am.
consider doing a double marker.
Sharing.
Double marker is, yes, ma'am, 100% double marker will be associated. That's the combined test.
No,
Including
there is the
procedures,
difference of
and you cannot do PGT. You can't do the sex of the. You can't determine the sex of the child.
Yeah, I think she's ready. There is a difference of opinion. If there is a structural abnormality, don't do it.
A structural abnormality. Yes, ma'am.
Yeah, NT is a structural abnormality.
Yes, ma'am. Yes, ma'am.
The other group says quit, because PAPE, if it is, or HCG, if it is high, then we know then we can think of one of the aneuploidies.
I mentioned, ma'am, structural anomalies don't do this thing, directly go in.
That you mentioned for NIPT.
Yes, ma'am.
We are talking of double marker. Okay.
Okay, ma'am.
Are
Okay.
you ready, Purnima?
Yes, ma'am. Good evening, everyone.
Slideshow, Dr. Purnima, put it on slideshow.
Slideshow.
Put the first slide. Perfect. You can start.
Good evening, everyone. I am Dr. Purnima from Ballari. I thank KSOGA and Ballari OBG Society for giving me the opportunity to speak on the prediction test for preeclampsia, that is fetal medicine foundation test and alternatives. So it is prevalent in 2 to 5% of the pregnant women, and in some African countries up to 8 to 12%. Preeclampsia is one of the leading causes of maternal and perinatal morbidity and mortality. Now, coming to implications, it causes around 76,000 maternal deaths per year worldwide and around 5 lakhs newborn deaths per year worldwide. This statistics is significant, and hence it is important to prevent and treat and save lives of the mothers. As we all know, definition of preeclampsia is it's a multisystem syndrome developing during the second half of the pregnancy, characterized by hypertension and proteinuria. Coming to the pathophysiology of preeclampsia, it's based upon the two theories, impaired placentation and maternal maladaptation. Our screening test for prediction depends on knowing these pathogenesis for preeclampsia. So impaired placentation causes placental hypoxia, release of trophoblast factors into the maternal circulation, platelet epithelial cell damage activation. So causing clinical symptoms of preeclampsia. So the anti-angiogenic factor S-FLET, which is increased in preeclampsia, and the placental growth factor is reduced in preeclampsia. Now, screening in the first trimester, second and third trimester. Screening in the first trimester identifies the high-risk pregnancies, and administration of aspirin reduces can substantially reduce the incidence of the preterm preeclampsia. Whereas screening in second and third trimester identifies the high-risk pregnancies and helps in intensifying the monitoring so that early diagnosis of preeclampsia can be made and the adverse perinatal outcomes can be prevented. So how do we predict and prevent preeclampsia? The screening in the first trimester, that is between 11 to 13 weeks, the FMF triple test, which includes maternal risk factors, the mean arterial pressure measurement, the biochemical marker, that is placental growth factor, and the uterine artery pulsatility index. So this triple test detection rate is 90% for early onset preeclampsia and 82% and 44% for preterm and term preeclampsia, with a false positive rate of 10%. When compared to NICE guideline, the detection rate is half of the triple test for early onset, preterm, and term preeclampsia. Now, so if the triple test is not feasible, then we can modify the triple test, like doing two markers, like doing double test. Like along with the maternal risk factors, we can do with the mean arterial pressure, which detects 65% of the time. Early onset preeclampsia, 60% and 43% in preterm and term preeclampsia. So with the mean risk factors, mean arterial pressure and uterine artery pulsatility index, where scan facility is available, it can detect the early onset preeclampsia by 80% and 70% and 44% for preterm and term preeclampsia. Where scanning facility is not available, we can combine the risk factors with the mean arterial pressure and the biochemical marker, that is placental growth factor, which again gives 85% of the detection rate for early onset preeclampsia, and preeclampsia less than 37 weeks, 73%, term preeclampsia, 47%. So after risk stratifying, doing the screening test, stratifying the women into low risk, where they go to the routine prenatal screening, and the high risk group of women, that is more than 1 or equal to 1 in 100, they are put on prophylactic aspirin, that is 150 milligram. Now, the FIGO guidelines also supports the universal screening of all the pregnant women for screening of preterm preeclampsia between 11 to 13 weeks gestation using a FMF triple test. However, where resources are limited, routine screening for preterm preeclampsia by maternal risk factors, mean arterial pressure should be completed in all pregnancies. And women identified at high risk should receive aspirin prophylaxis at 150 milligram per night, commencing at 11 to 13 weeks until 36 weeks. We do have an FMF calculator to stratify women into high risk and low risk. So this is available free in the website and also in the FMF mobile app. Now, is it feasible to screen all the pregnant women for preeclampsia? So in order to detect one preeclampsia, we need to screen 250 pregnant women, which is equivalent to screening of women for early onset GPS infection. And when compared to screening of cancers in the body, this number is far less, and we can do it practically and is feasible. And the feasibility of combined screening also depends on the measurement of mean arterial pressure, where it requires adherence to protocol undertaken. It can be undertaken by healthcare assistant after minimal training with the use of inexpensive equipment and take a few minutes to perform. And measurement of uterine artery pulsatility index training of the sonographers for quality assurance of their results. And it can be done. It can be done within a few minutes. Measurement of serum placental growth factor can be done in a same machine for screening for Down syndrome, but is cost. There is increase in the cost. And feasibility of the screening does not depend only on the basis of performance, but also on the implementation and health economic considerations. FIGO also supports in low to middle income countries the two-stage screening strategy. So where whole population undergoes first stage screening by maternal factors and mean arterial pressure, and a selected proportion of those considered to be at intermediate risk undergo second stage screening by placental growth factor and uterine artery pulsatility index. So there are also other guidelines like ACOG and the NICE guidelines, where the prediction of preeclampsia is done by moderate risk factors and high risk factors. Presence of 2 moderate risk factors and 1 high risk factors are considered to be an high risk for prediction of preeclampsia. As we discussed, NICE prediction is 47% for early onset and 44 and 23% respectively for preterm and term. And our own FOXI has come up with a risk scoring system, that is HTP gestosis scoring for prediction of preeclampsia, where a scoring of more than or equal to 3 women in a woman is considered to be in high risk for preeclampsia. These are the various risk factors given the score 1, 2, 3. So how do we prevent? So it is low dose aspirin between given between 11 to 14 weeks, that is before 16 weeks, 150 milligram up to 36 weeks. So prevention in the early onset preeclampsia is up to 82%. And if the women are compliant for aspirin more than 90% or equal to 90%, it can prevent up to 76% of preterm preeclampsia, and whereas almost nil in term preeclampsia. Now, screening in the second trimester. The objective for second trimester screening is to assess the patient-specific risk for developing preeclampsia, and on basis of such risk, define the subsequent management. Here, as the gestational age increases, the performance of the screening improves. So, the mean arterial pressure, uterine artery pulsatility index, placental growth factor predicts the preeclampsia 94 times for early onset, 85% less than 37 weeks, and 45% for term preeclampsia. Now, screening at 35 to 37 weeks. Why do we need to screen at 37 weeks? When compared to term and preterm, the incidence of adverse outcomes, that are severe hypertension, maternal morbidity, perinatal mortality, and neonatal admissions, the incidence is high in preterm preeclampsia, that is in the blue histogram. But however, the incidence of preterm preeclampsia is only 0.7%. So the major contribution for adverse outcome is from term preeclampsia. Hence, the screening at 37 weeks is important. The screening at 37 weeks main objective is to estimate the risk of developing preeclampsia and define subsequent management. Here, the new FMF triple test, that is along with the history, mean arterial pressure, biochemical markers such as S-fleet and placental growth factor predicts the preeclampsia 85% of the time. Now, an emerging biomarker is ophthalmic artery Doppler, which is an Doppler which identifies the peripheral vascular resistance in the brain. It is done. It is done when a woman in a lying down position by placing a probe over the closed eyelid, and the two peak waves in the systole. The ratio of the second peak systolic wave and the first peak systolic wave gives us the ratio, which is, if it is more than, it is a prediction for preeclampsia. So take-home message is to integrate the preeclampsia risk assessment as an integral part of basic first trimester evaluation protocol, where feasible, pragmatic practice, where resources are limited, routine screening for preterm preeclampsia by maternal factors and mean arterial pressure in all pregnancies, and reserving measurements for placental growth factor and uterine placental index for subgroup of population, to improve access to the prenatal services and encourage early booking. Screening identifies high-risk group and administration of aspirin prevent early onset, that is less than 34 weeks, and preterm preeclampsia less than 37 weeks by 82% and 70% respectively. Thank you.
Sundari?
Yeah.
Good, Punima. That was a lovely presentation.
Thank you,
Sundari,
ma'am.
ask the first question, please.
Yeah, Purnima, it was really a good presentation. It shows that you have really read well and your slides are good. Okay, your evidence given is very good. Okay.
Thank you, ma'am.
Now, I
Thank you.
would like to know, in your practice, what would you like to do routinely? You have spoken so many things. In your practice, practically, what are you doing for preeclampsia screening in all your women?
So we are doing the calculating the maternal risk factors, and we are doing the Doppler uterine artery pulsatility index. That is, when we send for anti-scan, at the same time we are doing the Doppler studies for uterine artery.
Are you doing the mean arterial pressure calculation?
No, ma'am. No.
Mean arterial pressure plus the maternal risk factors. How much is the sensitivity to diagnose? Only 2 if you have
Mean arterial pressure and
history, maternal
so
history.
it predicts the detection rate is 65%.
Yeah, 75 to 83% they say, even if you don't have a Doppler. But mean arterial pressure, you know how mean arterial pressure is calculated?
Yes, ma'am. So first it should be done in both hands.
Yes.
And the 4 measurements are averaged, and
Yes.
then it is taken. It's 2/3 of the diastolic pressure and 1/3 of the systolic pressure.
Don't you think it has to be practiced? It's a clinical method.
Yes, ma'am. It is a
Don't you
clinic
think?
method.
This is
It is a
something
clinic
nobody
method.
does.
Should be
Yes.
adopted.
Yeah, good. Okay.
Chinmay,
Chinmay?
ask.
Actually, I was going to ask the same thing, that do you think mean arterial pressure is doable, and should we make it a practice to start measuring the blood pressure like
Yes.
that? Because at least in fetal medicine clinics, we are able to do it. But again, I must admit that it is done only in the first trimester, because that's kind of a mandate for the first trimester protocol. But it would be something nice to incorporate in clinical. Like Madam said, it's a clinical thing. And when we talk of low resource settings, we have no excuse to say that we cannot do a blood pressure measurement properly and add to a significant amount of. I would like to ask, do you think the third trimester screening with the biomarkers is something that is practical for us? Or
Is
can
it
we just go
useful?
by clinical?
Chinmay, I wanted to know whether it is useful really at 35, 37 weeks doing a biomarkers.
No, I don't
Madam,
think.
for our setting in India,
Yeah.
because
It is-
the reason, the rationale by which it is followed in the West is to triage women who need admission or to keep the ICU beds for these women. But in India, it doesn't really make proper sense. In some settings, if you really have to justify why you are trying to take a woman up for delivery or why you are trying to withhold steroids, in those conditions, maybe it will give you some leeway to say that, this is the reason if somebody is questioning your judgment, you can do that. But in a routine practice, I think it's a very expensive test for a very little,
In our country,
output.
Chinmay,
Yes, ma'am.
it's not indicated at all. Now, Punima, you
Yeah, I
did.
tell you, at 37 weeks, even if you see a rise of BP, you
will
can just follow them up for 2 or 3 days. And if it is high, probably it warrants for a So termination of pregnancy, it is easy, 37 weeks, we can deliver her. Isn't it? Instead of going for all this, and how much you want to prolong the pregnancy after 37, doing all these markers, we have to be practical in our country.
Absolutely,
We
ma'am.
can't
And
just
the
Can we move to the
with
next
our
one, ma'am?
patients
we
is
cannot
different.
just
Move to the
apply
next
the
one.
Western standards to
Neha
us.
has-
Unfortunately, we don't
Absolutely.
do that.
She has presented
Agreed.
the theoretical aspect, but we have to decide that in practice it doesn't work.
Yeah, that's what.
That's
Okay,
one.
fine. Anyway, it's a wonderful presentation.
I
Thank you,
want to
ma'am.
ask
Purnima?
Thank you, ma'am. Thank you so much, ma'am.
Purnima, I want to ask you, why don't we do SFLT in the first trimester?
SFLT is not a good predictor in the first trimester.
Why?
It is because it increases, the S-split increases in an established pregnancy, preeclampsia, it increases 5 weeks before. That's why in the first trimester, we can't use S-split.
See, S-split starts rising only after 22 weeks. So it is not there in the circulation. Okay, or even if it is there, it is an immeasurable form. So that is the reason why we don't do S-split.
Purnima, you should know why these
We will
things,
go to
where
the
they are
next one,
produced,
ma'am. We are
and when the
running
placenta.
short of time, ma'am.
Yes. Okay,
Yeah,
fine.
we'll
So
just
thank
go
you.
up.
Sorry. Dr. Jolin? Thank you, Dr. Purnima.
Thank you, ma'am.
Stop
Thank you.
sharing.
Well done, Purnima. Well done.
Thank you, sir. Thank you.
Good evening, ma'am. I think I have to replace Dr. Purnima's slide sharing.
I think she stopped.
Yeah. The slides are visible,
First
ma'am?
slide, yeah, first slide, please.
Yeah.
Yeah, on slideshow.
This
Perfect.
opened without any problem. Good, Joyli.
Start, please.
Good evening, and this talk is on screening for gestational diabetes in India. Although the webinar series is rightly named Controversies and Consensus, my idea here would be to also add a clarity to the screening of gestational diabetes in India. We are navigating the options, and hopefully at the end of this talk, I'll help you to choose the best path. I'm Dr. Joylin D. Almeida from the Mangalore Obstetrics and Gynec Society. I thank the KSOGA Clinical Research Committee, Dr. Durgadas, Dr. Srimati, and the team for giving me this opportunity. Every day, over 40,000 women in India give birth, and 4,000 of them, 1 in 10 have undiagnosed gestational diabetes. Every 1 in 10 pregnant women silently walks into high-risk pregnancy, and 1 in 6 live births are affected by hyperglycemia in pregnancy. So what if a single glass of glucose could change the future of the baby and the mother and her baby? What if the test that you take today decides 2 lives tomorrow? Gestational diabetes affects 10 to 14% of Indian pregnancies, and if we pick this up, we prevent complications like macrosomia, preeclampsia, neonatal hypoglycemia, shoulder dystocia, and future diabetes in the mother and the child. We have multiple screening strategies, and this leads to a lot of confusion among practicing practitioners. For broad definitions, we have GDM, overt diabetes, and early gestational diabetes. All of us who practice know that gestational diabetes is between 24 to 28 weeks, onset of glucose intolerance for the first time. Overt diabetics are hyperglycemia preconceptually, periconceptually, or in the first trimester. And there's a new entity, especially what the endocrinologists use. It's called as the early gestational diabetes mellitus, gestational hyperglycemia that happens before 24 weeks, which fulfills the criteria of GDM, but excludes out overt diabetes mellitus. So early detection is the key. And in screening for gestational diabetes mellitus, especially screening means prevention along with timely intervention. Now imagine this. A woman in rural Karnataka walks 5 kilometers to a health center. She hasn't eaten since 6 a.m. in the morning. She's told that she must fast and come back another day for her gestational diabetes mellitus fasting test. Weeks later, a baby is born, severely overweight, and struggles to breed at birth. Fishing nets must be wide enough to catch all the fish, but also should be fine enough to avoid the waste. Screening tests have to be like fishing nets, sensitive enough to catch all the GDM cases, but specific enough to avoid an overdiagnosis. Why is screening in India unique? We have a high-risk population by ethnicity. We have a diverse healthcare accessibility. We have a rural population which doesn't have access to healthcare, lab tests, etc. We have an urban population that has everything at the access of a fingertip. We have cultural and logistic challenges where mothers and grandmothers believe that eating ghee and sweets is good for the baby. And we have an urban population which is very much keto, like a keto-based diet and controlling their calories. We require a cost-effective yet a simple test to cater to our entire wide range of population. So let's cast the net, and I will now tell you about the various screening options that we have. So for the sake of this talk, we divide the screening tests that are widely available now into 4 parts. First is the International Association of Diabetes and Pregnancy Study Group. This is also accepted by the WHO. It is a fasting 75 grams oral glucose tolerance test. Here, we check the fasting plasma glucose 1 hour after 75 grams of glucose load and 2 hours. 92, 180, and 153 are the cutoffs. This is also accepted by the WHO, and this is one of the standard tests that a lot of medical colleges and tertiary care hospitals accept. The ACOG, which is catering more to the NICE guidelines and the UK population, accepts the two-step testing, which is the GCT and then the GTT. So we know the GCT is 50 gram irrespective of fasting, and more than 150 then pushes it on to a GTT, where we do a fasting 100 gram glucose load, and then we take three values, 180, 155, and 140 are the cutoffs. The more popular and widely known single-step non-fasting test, which is endorsed by the Government of India, is by the DIPSI. That is Diabetes and Pregnancy Study Group Guidelines. And this was mainly tailor-made for the Indian population. So we have the 75 gram WHO one-step fasting test. We have the ACOG two-step GCT and GTT. We have the DIPSI, which is a Diabetes and Pregnancy Study Group non-fasting 75 gram test. And then we have the simpler tests like random plasma glucose and our hemoglobin A1C. So this is the two-step testing, which a lot of institutes, including mine, which is in Bangalore, practice. We do the GCT and then go ahead and do the GTT. The other strong swimming techniques are the oral glucose tolerance test, where we give a 75 gram glucose load. In this, fasting is required, time is 2 to 3 hours, slightly costly, and yes, WHO recommended. So the WHO recommended IADP-SG 75 grams fasting test is the one which is like top on the list. The DIPSI is a single test, no fasting required, 2 hours is the time, cost effective, and endorsed by the Government of India. The HbA1c is not a recommended test, no fasting required, 5 minutes, tad bit more expensive. And the fasting plasma glucose requires fasting, and the time required is about an hour, and it is less expensive. So many tests, the OGTT, the DIPSI, the HbA1c, what do we choose? Too many tests, too little clarity, and the clock is ticking. What are our battles? Should we choose a fasting test or a non-fasting test? Should we do a one-step test or a two-step test? Should we follow the Indian guidelines or the global guidelines? So we have these following battles, and basically it's a battle between simplicity and accuracy, and feasibility and standardization. And we in India know what exactly we need to choose. Sorry. So the fasting plasma glucose is one of the screening tests. There's no clear fasting plasma glucose cutoff for diagnosing GDM, because we know that the risk increases as the fasting plasma glucose levels increase. A person who has an FPG of more than 92 and later on moves on to have a normal GTT in the subsequent pregnancy is linked to outcomes like large babies, preterm birth, or NICU admissions. So doing a fasting plasma glucose as an initial screening test isolatingly may have some value. Half of the GDM cases reserved to normal OGT at 24 to 28 weeks. So what does this mean? Is our diagnosis of GDM in early pregnancy and overdiagnosis? Fasting plasma glucose between 110 to 125 raises the GDM risk in the lower range groups, and fasting plasma glucose has low sensitivity for GDM alone. The popular DIPSI method, which is popularly known and spoken about by all, the 75 gram non-fasting test tailor-made for India, but blood glucose levels measured at 2 hours, anything more than 140, is diagnostic of GDM. Pros, no fasting required, government recommended, one-step test, and ideal for low resource settings, especially for our women from rural Karnataka who had to walk 5 kilometers to come for a fasting test. The side effects or the cons, it may underdiagnose GDM, less standardized, not routinely acceptable all over the world, and poor reproducibility. So DIPSI is a practical single-visit non-fasting test, but the fallacy is it misses around 40%, and some studies have quoted even as much as 72% of GDM cases, and that is why it is not validated globally. It can be used as a preliminary tool, but probably not as a definitive tool for GDM. So can a test that skips fasting really be trusted, like the DIPSI? And is this the only realistic option that we have in rural India? Why the non-fasting DIPSI is more feasible in India? We have cultural, practical, economical, and compliance issues. We have women who skip fasting due to nausea. We have people who cannot travel to long clinics, and this also happens in a lot of centers where they don't have labs close by. We have economical issues, and because of these issues, compliance is reduced, and that is what makes DIPSI probably the best test that we can have. The standardized test, which is the 75 gram WHO IADP-SG OGTT, this is a test which has a sensitivity and specificity of as high as 85 to 95%. This is actually practiced by a lot of medical colleges and standardized centers in India, where we have a fasting 75-gram glucose and we check the blood sugar levels at 1 hour and 2 hour. It is highly sensitive and specific, as much as 85 to 95%, but it requires fasting to 2 to 3 hours of testing and not very practical in low resource setting. So here we do a fasting blood sugar and 1 hour and 2 hour and then diagnose GDM, but just a fasting blood sugar of more than 126, 2 hour of more than 200 and more than 200 without symptoms diagnoses overt diabetes. The limitations of this test is that it increases physiologically across the trimesters. So interpreting an OGTT in pregnancy is very critical. The test burden, 8 hours of fasting, the patient has to do 3 blood samples and poorly tolerated by patients. Early GDM, which shows a high FPG, I said, later on will actually manifest with elevated plasma postprandial glucose levels. And the first trimester OGTT cutoffs are unreliable in predicting future diabetes in the subsequent pregnancies. These are some of the limitations of the OGTT, although I personally believe that this is one of the gold standard tests. So let's discuss. A 30-year-old GRABDA3 obese woman comes to the NC clinic at 16 weeks. In her last pregnancy, she gives a history of prolonged and a difficult vaginal delivery. When do we screen this patient? Our standard guidelines are to screen between 24 to 28 weeks. But would we screen this patient early? If we did, what tests would we want to use? A 28-year-old primary gravida comes for her first antenatal visit for 10 weeks. She is obese and has a history of PCOS. Both her parents are diabetic. Should we screen this patient early as 10 weeks? And if so, what are the tests that can be used in the first trimester? So in the first trimester, an FPS of more than 126 and HbA1c of more than 8.5 or a random blood sugar of more than 200 on just any random testing can be used as effectively as a screening and a diagnosis for overt diabetes mellitus. This is very much applicable for a lot of our patients. Unlike the West, we do not undergo regular health checkups. Some of our patients undergo their first blood test only in pregnancy. So in these patients, doing these random tests also could be used as a screening test so that we don't miss out on our cases of diabetes. A study done in the New England Journal of Medicine, a pragmatic randomized clinical trial of gestational diabetes screening said that despite more diagnosis of GDM, 2 times more diagnosis with the one-step approach, there is no significant group differences in the risk of primary outcomes. So the fuss that we're making about the one-step and the two-step approach, if the ultimate outcomes in terms of perinatal and maternal complications is not affected, do we really need to have so much of a dilemma in choosing? An interesting study in the Acta Diabolica, which probably was one of the studies that based for DIPSI to come into being, is that when we did a fasting OGTT, a lot of 78% of patients did not come back for a fasting test. And that is why we said we want to do a non-fasting test, which was more feasible. The incidence of vomiting in non-fasting patients versus fasting patients was not any different. And the DIPSI test has a poor sensitivity.
7 minutes up, only 1 minute left.
This missed as much as 72% of women diagnosed with gestational diabetes. So random blood sugar, very low sensitivity and specificity. Very interestingly, the STRIDE calculator, a modern twist, the Fetal Medicine Foundation calculator for screening gestational diabetes in pregnancy, is a modern decision supporting tool for pregnancy diabetes screening. And we can use this to screen for gestational diabetes, especially in the modern population. We have a lot of controversies, like I rightly mentioned, patient-related barriers like lack of awareness, contact, biochemical aspects, barriers in the healthcare system. And also, why do we not have a consensus? We're having a constant tug of war about which test is the best, which guideline is the best, and what are our cultural differences. This is the last slide and the most sensitive slide of my talk. It is a sensitivity and specificity of all the tests that are available to us. And as with everything good in life, anything which is highly sensitive does not meet with a test that is highly feasible. And that is the difference between all the tests that are randomly available to us. The consensus in India, DIPSI is good for mass screening, OGT is used in high-risk women, and STRIDE is used in early risk prediction. So as I conclude, the final verdict for India is use DIPSI for primary screening. One size cannot fit all. STRIDE marker will complement but not replace the testing. For rural health worker with a one-shot at screening, DIPSI is actually gold standard. And context matters. It's important that we see the entire big picture. Is screening important? Are we going to pick up our patients who have gestational diabetes and prevent the complications in a rural setup? Which test is actually the best? Balancing practicality with precision is the key. Let's stop asking which test is perfect. In fact, let's start asking who needs it the most. And that's how we should win against GDM with an accurate, affordable, and an accessible test in our setting. Thank you.
Ma'am, I can give only 2 minutes for questions, ma'am.
I'm sorry, I exceeded the time. Also, ma'am, before the questions, I want to thank Srimati ma'am. And like Durgata sir rightly mentioned, she's a perfectionist. And I want to thank her for having motivated me in the entire last week to prepare my presentation. So thank you, ma'am.
1 more minute of your question time is gone, Joylene. Okay, Chinmay, ask your question, please.
Joylene, tell me, what is the biggest, deterrent to screening? What do you think?
Right now in practical life, it's the fact that a lot of patients, if we like in our hospital, ma'am, we don't do the fasting test, we do a GCT. So the moment we have an elevated GCT, getting a patient to come back with a fasting test is probably the biggest problem ever. But that is kind of like changing now because people have labs which are very much close to their houses. But again, doing the test depends on the standardization of the lab. Doing it at a good lab makes a difference. And that fasting cutoff of between 92 to even 120, even 1 milligram elevation of that blood glucose makes a difference to us. So it's both
So
ways, but
if somebody asked you what was the single most important intervention that you would do in antenatal care to make the screening happen, what would that be?
right now I would think it would be the FMF stride calculator, because we are completely online in our hospital. So we do everything on the computer and we have the internet available. It's accessible. So something simple, small that our postgraduates and residents can start off and can be implemented in our antenatal screening. With the rise of diabetes,
How would you rate that against patient awareness so that the patient themselves realize that, we need to get this screening done?
patient awareness would be the first. But I think because you're more techno, I wouldn't say tari, but moving towards technology, I said stride, but yeah, patient basics is always the best.
Can I make a point here? I'm not asking you, Joylene, because
Yes,
out on your questions now. But
Yes,
the thing is, there is something called a fetal glucose steal, which all of us should be aware of. I know I'm going out of the context here, but it's very important because very few people know that in the first trimester, the first visit, not 24 to 28 weeks, that is okay for Caucasians, but not for Indians. We have to catch her at the first visit. And when we catch her at the first visit, we have to do it for the simple reason that the sugars are higher earlier in pregnancy in people who are in women who are going to develop GDM later on. But what happens is if we don't catch it at that time and you do your test at about 16 weeks or 20 weeks, the problem is that the high sugar in the mother stimulates the pancreas to secrete insulin in the fetus. The pancreas starts developing at 4 weeks after conception. So once, insulin increases in the fetus, what does it do? It needs a substrate. So it takes the glucose from the mother. So what was hyperglycemia in the mother, which we did not check as soon as she came, becomes normoglycemia in the mother because the fetus is taking off. What happens is later when you check her sugar, you find that she is normoglycemic. But what you find is that the baby has already got a programming done. That baby can become a macrosomic. That mother can have a preeclampsia. So this is called the fetus glucose steal. So most important is check the mother as soon as she comes and not later on. There are 2 more things which Dr. Sheshaya, who is like the diabetes king of India, he has mentioned that any HbA1c beyond 5.3 in the first trimester or any postprandial, not even a fasting, not even DIPSI, a postprandial more than 110 at 10 weeks can predict GDM to the extent of 95.9%. And only 4% of those whose fasting is, whose PPBS is less than 110 at 10 weeks or the HbA1c is less than 5.3 develop GDM. So there are new markers. Let us look into it, which suits our population, and let us not blindly follow Carpenter or Kuston or ADPSG guidelines. Thank you.
Thank you, ma'am.
Excellent, Jolene. I wanted the last sentence of Dr. Jyotika Desai. I wanted the key message. 10 weeks that postprandial and H1AC is the upcoming thing. Dr. Shesha has coined it. And I wanted this message to be conveyed to the society. Thank you, madam.
Points. Also, as per the Indian guidelines, we have to screen the patient at the first visit. So even for the residents and the postgraduates from my college who have joined, we have to screen our patients at the first visit when they come for that first.
No, this is 10th. It is 10th week. That's what the latest guideline. Okay.
Thank you.
Thank you, Durga.
Thank you.
Me
Thank
to
you, Dr. Jolie.
out.
And we have Dr. Rashmi Sarangavi, and she's going to be speaking on preterm labor. Can we prevent it? Dr. Rashmi? Dr. Rashmi?
Yes, ma'am. Yes, ma'am. I'm sharing my slide, ma'am.
Yeah. We can't see your video.
Yeah, ma'am. Just a minute, ma'am. Good evening, everyone. I'll share my slides.
Thank you.
Oh my God, ma'am. Yeah.
You want me to share for you?
No, ma'am, I did.
You're done.
Yeah. Is it seen, ma'am?
It is not seen,
Yeah.
ma. Go down, click on the share button, share screen, and
Yeah, I've done it, ma'am. I've done it.
no,
That
ma, it's not coming, ma. Only you are coming, ma.
Come out and share again.
Come out and share.
Yeah, escape. I'm doing it once again.
Not happening?
Okay. No, ma'am.
Okay, doesn't matter.
Let her do it.
Timothy, you've got it?
Share entire screen, ma'am.
Yeah, share screen.
Yeah,
and
I've
go
done.
to the PPT now. Go to
Yeah.
the PPT screen.
Click on the share and then PPT will be seen, ma. Just go to the PPT.
She has shared it with you, Srimati.
Yes, ma'am, I have it ready.
When you share, you'll see multiple windows. You go to the window where you see your PowerPoint.
Dr. Srimati will do it for you.
Yeah.
Okay.
Is it okay, Dr. Rashmi? Or
They will be more comfortable.
Ma'am, it's more comfortable if I will do it once
Yeah,
again, ma'am. Actually,
Okay.
What is happening when you're putting on the share button? What are you seeing?
ma'am, when I'm putting the share button, I'm able to see many windows.
Window.
That
So
your
the one
window
in
you
which
see.
your PPT
The
is open,
slides.
click on that window.
Click on your PPT. Only on that.
yeah, perfect.
Yeah.
So put it on slide.
Now put it on
Yeah.
share. You say that again share there.
Share is open.
You have to click share there.
So open your presentation, no?
Okay.
It is seen, ma'am?
Yes.
Yeah, yeah.
Yes.
Slide
Make it
show.
a slideshow.
Beautiful.
Yeah, slideshow
Put
I'm
it on
doing, ma'am.
slideshow.
Sorry for the
Yeah.
inconvenience.
Okay, it's
at the
okay.
beginning.
Don't get tensed up.
It's okay, start.
Please.
Go back to your first slide and start.
Good evening, everyone. My topic is preterm birth and can we prevent it? By definition, preterm birth is defined as delivery occurring between 20 weeks of gestation and up to 37 weeks of gestation. It is divided into 4 types based on the gestational age. Less than 28 weeks, extremely preterm, 20 to 32 weeks, very preterm, 32 to 34 weeks, moderately preterm, and 34 to 37 weeks, late preterm, as per WHO classification. The incidence of preterm birth varies between countries, the range of 5 to 13%. India tops the list of top 10 countries with greatest number of preterm births. Preterm birth is a leading cause of perinatal mortality and morbidity with so many short-term and long-term complications. Why is it so important to predict preterm birth? Just by increasing the gestational age of delivery from 23 weeks to 28 weeks, the survival rate of the neonates increased from 8% to 74%, which is much huge. And at later gestational age, that is more than 32 weeks, just by delaying by few days, by gaining time to cover corticosteroid course, we can reduce the complications related to respiratory distress syndrome. Preterm birth is multifactorial. There are many factors like uterine overdistension in case of multiple pregnancies, decline progesterone action due to many causes, cervical disease like previous cervical surgeries, LEDs, cone biopsy, etc., breakdown of maternal fetal tolerance, stress, smoking, which indirectly increases corticotropin releasing hormones and cause preterm birth, infections, vascular disorders, gestational senescence, etc. Among the 100% of preterm births, 25 to 30% are due to unexplained causes. Why is it so important to predict preterm birth? I have told. Now, which risk scoring systems can be used in predicting preterm birth? First of all, the most important thing is history, that is maternal factors, cervical length assessment by TVS, transvaginal sonography, home uterine activity monitoring and per-vaginal digital examination, less recommended as screening part, screening for asymptomatic bacterial and genital tract infection, which will be explained later, various biochemical markers. History and risk assessment forms the main important part, wherein previous history of preterm births, mid-trimester pregnancy losses, history of smoking, congenital uterine anomalies in the mother, multiple pregnancies, recurrent vaginal bleeding in first trimester, that is threatened abortion history, asymptomatic bacteria, genital tract infections, previous multiple cervical operations like LETS or cone biopsy. This is the FMF calculator, wherein so many factors, maternal factors are taken into consideration and the risk of preterm birth is calculated, like maternal age. Extremes of age patients who are pregnant are more prone for preterm birth. Maternal height, shorter the height, more prone for preterm birth. Racial origin, Southeast Asians are more prone for preterm birth. ART pregnancies are more prone for preterm birth. Smoking increases the risk of preterm birth. Previous history of one or more second trimester abortions or preterm birth may be iatrogenic or other causes. They will lead to more preterm births in this pregnancy. This is based on this particular paper, which says maternal history is more important than when compared to biochemical markers or placental perfusion at 11 to 13 weeks of gestation. Now, let us discuss about universal screening of cervical length. How would it help? It will be helpful to us. And what does the guidelines say? KSOGA recommends universal screening of all the pregnant women with transvaginal ultrasonography between 18 to 34 weeks in 18 to 24 weeks in singleton pregnancies, which I'll discuss in detail later. RCOG, on the other hand, advocates targeted screening. That is, it divides into low risk and intermediate high risk. And in such intermediate high risk women, pregnant women, transvaginal ultrasound is done between 18 to 24 weeks. And if the cervical length is less than 25 mm, then it advocates transvaginal cerclage in such patients. ACOG, cervix is often visualized on TIFA scan transabdominally, and if the cervical length is less than 36 mm, then TVS is considered. KSOGA guidelines in asymptomatic every pregnant woman where there is no history of previous spontaneous preterm birth, single measurement of cervical length using transvaginal sonography between 18 to 24 weeks is advised. If the cervical length is more than 25 mm, routine antenatal care. If it is less than 25 mm, daily vaginal progesterone until 36 weeks. Follow-up of cervical length every 1 to 2 weeks until 24 weeks. And if the cervical length is less than 10 mm, then cervical encerclage is considered. If in pregnancies wherein they have history of previous second trimester abortion or preterm birth, that is between 14 and 27 weeks of gestation, second trimester abortions, then screening is done at an earlier gestation age, that is at 14 weeks. Whereas if the preterm birth is at 28 to 36 weeks, screening is done at 16 weeks for the first time. If the cervical length is more than 30 mm, repeat cervical length measurement every 2 weekly until 24 weeks. If it remains more than 30 mm, routine care. If it is less than 15 mm, consider cerclage. If it is between 26 to 29 mm, repeat cervical length measurement weekly until 24 weeks. And if it remains 26 to 29 mm, continue routine care. For logistic reasons, the screening of cervical length is always above 14 weeks. That is in second trimester usually, because in first trimester, if we do cervical length, it tends to overestimate cervical length because lower uterine segment is not properly formed. If the patients present with preterm labor symptoms, swab collection is done, though not in our country, because by the time we get the result, the patient will deliver. But still, if the contractions are there, more than 3 centimeter dilatation, then consider active management, hospitalization, admission, tocolysis. Till at least we cover corticosteroids. If it is between 24 to 34 weeks, magnesium sulfate for neuroprotection can be done. If the cervical length is less than, like if it is more than 30 mm, then conservative management is preferred. If it is between 15 to 30 mm, we can consider fetal fibronectin, which I'll discuss later. Rest, like placental alpha microglobulin and insulin growth factor, like binding protein, which are not advisable in India. RCOG divides all the pregnant women into this category, that is low risk and high risk. High risk in the sense previous history of second trimester abortions or preterm birth or cervical procedures or multiple pregnancies or previous previously diagnosed congenital uterine anomalies, etc. They are considered as intermediate high risk, and then they are screened. Transvaginal ultrasound is the gold standard and is highly sensitive, wherein we measure total cervical length in magnified sagittal view from external os to internal os with empty bladder. And the absence of short cervix, though the funneling is there, but if the cervical length is normal, then it is not a predictor of preterm birth. Is the finding of a short cervix relevant in a low-risk woman? Definitely yes. Women with history of prior spontaneous preterm birth account only for 10% of the births which are below 34 weeks. Asymptomatic bacteria. Due to limitations in the data, US Preventive Service Task Force in 2019 downgraded the recommendation for asymptomatic bacterial screening from category A to category B, though in high-risk patients or with previous history of preterm birth, second trimester abortion at 16 weeks, we can consider urine culture, and if the count is more than 1 lakh bacteria per ml, then we can treat her with proper antibiotics. Bacteria vaginosis has been associated with preterm birth, but interventional studies and treatment of asymptomatic women have not shown to reduce preterm births and hence not recommended as per ACOG guidelines. Fetal fibronectin. If cervical length screening is not available, then it can be used. The presence of fetal fibronectin in cervicovaginal fluid from 23rd to 33 weeks is considered abnormal, though it has a high negative predictive value of more than 95%. In India, cervical length measurement is much easier than compared to fetal fibronectin. And how can we prevent it? By many modifiable causes, like if the patient has history of smoking, we can ask her to stop smoking. Stress, she can reduce. Lifestyle modification, proper rest, 2 hours sleep in the afternoon and 8 hours sleep in night. Modifications in the lifestyle help us to reduce the preterm birth, but not totally. Treatment is mainly by progesterone and cervical encerclage. Progesterone acts at various levels like placenta, amniotic membrane, cervix. At all the levels it acts and decreases the risk of preterm labor, reduces the preterm labor. NICE RCOG guidelines tells us that if there is either history of preterm or cervical length of less than 2.5 cm, one among these two are there, then vaginal macrolide progesterone is advised 200 mg. If both history plus cervical length, that is previous history of second trimester abortions or preterm birth plus cervical length transvaginal, if it is less than 2.5 cm, then cerclage and vaginal macrolide progesterone both are advised. If previous transvaginal cerclage has failed, then transabdominal cerclage is advised. Antibiotics in case of proven asymptomatic bacteria and bacterial vaginosis. No role of prophylactic tocolysis for prevention of preterm birth, but if there are contractions, then we can use anyways. Once patient goes into preterm labor with contractions, then tocolysis like nifedipine, atosiban, corticosteroids, magnesium sulfate for neuroprotection, antibiotics, erythromycin steroid is used. Future considerations like artificial intelligence, wherein there'll be more calculators and more, AI generated cervical length measurement. Studies might consider that as an option, and metabolomics, future considerations are required. Elastography, cervical stiffness might, future studies might help that whether that can be taken into consideration for screening preterm birth. These are my references. And finally, can we prevent it? No, we can't totally prevent it because 30% of them have unexplained causes. But by screening, we can predict them and we can try to delay the preterm labor so that it will reduce the morbidity and mortality of both the mother and the neonate. Thank you.
Thank you, Rashmi. You did a very good job. Sundari, can you ask the first question, please?
Lakshmi, you said that erythromycin in a preterm labor. Is it advised?
Yes, ma'am. If they go into preterm labor, then erythromycin steroid is the preferred antibiotic.
Yes, it is a PROM.
Yeah.
In a preterm labor, there is no indication for. And what about vaginal dysbiosis and then the preterm labor? What do you say about it?
Ma'am, if there is a history of vaginal discharge, then definitely we have to treat the patient. But routinely as a screening measure, there is, the guidelines say that there is no need of doing per speculum examination, screening all the patients whether they have vaginosis or send a swab for culture. But if they have symptoms and if they give that history, then definitely it has to be treated because it is one of the important causes which might lead into preterm labor, risk factor.
Chinmay?
How do you know simple? Sorry. Okay, Jyotika, go ahead.
Chinmay, can you ask?
So, when it comes to cervical length, do you think we should be doing a universal cervical length screening in the first trimester?
First trimester, no, ma'am, because it tends to overestimate the cervical length, and we'll be very happy that it is very good. But at 18 to 24 weeks, definitely we have. I personally do. I follow ISPO guidelines. And I do TVS in all the TIFA patients. And because it also helps us to know like urinary PI more easily during TIFA scan. Transvaginally is more easier to do, and placental position also it helps. Overall, it will help. So I'll definitely do TVS in all the patients to screen cervical length also.
So what is your argument against first trimester screening?
Now, first trimester screening for cervical length per se, it tend to overestimate, but still, if we do, no harm. But the patient should also feel comfortable, ma'am.
It is not overestimation. The lower segment is not formed. So when the lower segment is not formed, you can't differentiate between the cervix and the myometrium.
Ma'am, that's why we take it in a longer time, longer size. Yeah.
Basically,
only after ideal 14 weeks, but in cases where they have, you've done a very bad cone and a lot of more than 1 centimeter of the cervix has been taken away, then maybe you start a little earlier at 12 weeks also. But otherwise, there's no indication to do a TVS at
first time.
Because now we do the anatomy assessment of the fetus in a lot of detail in first trimester, which sometimes requires a transvaginal assessment. So there's no harm in mentioning and measuring the thing. Do not act on it immediately unless you see something grossly or there is a history. You mentioned conditions where there are failed vaginal cerclages in the past. There is history of preterm birth in the past. So it may make sense to have a first trimester assessment. If it's grossly short or you see some changes there, that's a good time to act. And especially the conditions where you want to put in transabdominal cerclages, it's a good thing to see the cervix in the first trimester, and especially after you ensure that the baby is structurally normal. So there are some, see, at every stage you have to use your clinical judgment. So observation is never a problem. Acting on that observation without putting clinical judgment is the problem. So I would say do it. Act on it only with your judgment.
Considering all the factors, yes, totally agree.
There is one question, ma'am, if you want to answer for the audience.
1 minute.
They have asked cervical length.
1 minute. Can you find out if the cervix is insufficient? We do not use the word incompetent anymore. By a vaginal examination.
Effacement will help us clinically as a screening method, though it is not used. But if the patient is complaining of pain and if she's symptomatic, doing digital examination in such symptomatic patients, definitely it is helpful, ma'am.
See, the reason why I mentioned this was, it is helpful, no doubt. But the reason is that in the cervical insufficiency, the taking up starts from the internal loss, not from the external loss. So when you do a vaginal examination, you cannot make out what's happening at the internal loss. You mentioned effacement, which is very correct. So only when it is effaced, then, or if it is dilated, then you can make out. Otherwise, you can't.
Yes,
so even if you say the cervix is short, maybe the vaginal portion is short.
Yeah, not entire length we can
exactly.
make out.
Realize all the fallacies. Okay.
Yes, ma'am.
Yes, one question is there, ma'am. Cervical length, do we measure in early pregnancy dating scan? I think we have already answered it, but maybe one word from Dr. Chinmay about it.
She's just answered the same thing.
Yeah.
So at the dating scan,
at
the dating scan, we don't actually think, because very many times you will get a shorter length actually at the dating scan. You don't panic with that. Like Madam said, that there is a dynamics of cervical remodeling. So in early pregnancy, let's not stretch it.
Yeah, thank you.
And even there are, though you mentioned 3.6 centimeters per abdomen, but actually any abdominal per TAS, if the cervical length is 3 centimeters or less, then you have to follow it up with the TVS, not 3.6, 3 centimeters, because 3.6 is something which is normal. Okay.
Thank you, ma'am. So thank all the speakers and the judges. So it was an excellent session. I think next time we just probably have to make sure the technicalities are looked into so that we don't run out of time. So thank you very much.
Srimati, 1 minute. All the 4 speakers have done extremely well. I want one feedback from the speakers. Yes, I want one feedback from how you have felt. Please put at least in a WhatsApp to Srimati. You may not be accessible to KSOGA. See, we are trying to do something new. We want the feedback from you also. all the four speakers, so that can we improve or anything. Please put the message to WhatsApp message to Srimati. Okay.
So it was really
Thank you.
very grateful for us also to get updated, and always Srimati ma'am was guiding us, and now also we are improving that whatever we have
Yeah,
prepared, some
put it in.
points clinically
Yes,
useful or
thank
not.
you, thank you,
Thank you
thank
so
you.
much,
Yeah,
everyone.
put your feelings and to Dr. Srimati. Okay.
Sure,
Thank
sure.
you,
Thank
thank
you
you.
so much.
Thank you, sir.
Thank you.
Thank you. So we look
Thank
forward to
you.
the next webinar, which will be on fertility issues on 10th of June. Dr. Raju sir has expressed his inability to join because he has got a clinical emergency. So I would request Dr. Chinmayratha to do her talk on extended inverted pyramid of care. As we already introduced Dr. Chinmayratha, I would request her to start her talk, please.
Thank you. Thank you so much, Dr. Srimati. At the outset, I thank Durga Das sir, Jyotika madam. And this has really been a very refreshing webinar because it's a very, very new idea. And I think all the four presenters show a lot of promise, and we will expect to hear from them again and again on various platforms, which I think is the concept behind having this kind of a webinar, encouraging the youngsters and getting them to, present. So it was very refreshing. And a lot of what I will be discussing as the part of the extended pyramid of antenatal care will be overlapping with things that we've already heard. And actually, the speakers have done a lot of justice and a lot of detailing of the screening. So I'm not going to go into the details of the screening, but it's an interesting topic about the extended inverted pyramid of antenatal care. So what is antenatal care? Antenatal care is the care that is given to a pregnant woman from the onset of pregnancy till the time of delivery with specific aims. And those aims are to ensure that the pregnancy is safe, to reduce stillbirths, to and ultimately end up in a healthy mother and a happy mother and a healthy baby. So various timelines have been talked about in the like in the preceding discussions. We need to screen for different problems that happen in pregnancy. We need to have correct interventions that is going to modify the safety profile of a pregnancy, and all these were traditionally put through a pyramidal approach. So this was one of the path-breaking discussions which happened almost about a decade ago, when the figure A, which shows the traditional pyramid of antenatal care, this was published in the United Kingdom, and this is what they used to do, that when people got pregnant, they would go to the doctor roughly in the first 3 months, and at some point they would be registered as an antenatal patient. They would be told to do this and that, and towards the second half of pregnancy, their frequency of encountering the doctor would increase. And towards the last part of pregnancy, they'd be seeing a doctor almost every week. And the most important intervention in obstetrics was considered the timing of delivery and delivery itself. So everything, the antenatal care was masked around the time of birth. And that is why it was a pyramidal approach, with the base of the pyramid at the time of the third trimester and the birth, because the obstetrician was supposed to be the person who guided birth. Over a period of, say, 50 to 75 years, people realized that, if you just do not do anything in the first trimester, you are missing out on many things. In recent times, during the border conflict, we went through this again and again, that, if you fail to plan, you plan to fail. So that is what many of the leaders told us, that we will have a response which will be delayed, not delayed because we are lazy, but because we are spending that time in planning. And if you spend that much time in planning, your end result is precision and your end result is success. So the same thing worked with the antenatal care, where the pyramid, which was based with the third trimester as the period of maximum intervention, was considered to be inefficient. And therefore, in the present scenario, the concept was of inverting this pyramid of antenatal care, putting the base of the pyramid at the top. That means in the first 12 weeks of pregnancy, you did your maximum hard work, so that towards the end of pregnancy, you can breathe and, relax on some cases and think that, yes, these are just pregnant women who won't have any risk factors, and they can go on to, routine care, what we call in. We never know who's a low risk pregnant woman, but still you screen them and find out that they are unlikely to develop major complications. So this was the concept of inverting the pyramid of antenatal care. And in the first trimester, what started with the NT scan, about which we've discussed a lot, the early imaging for fetal anomalies, uterine artery Doppler, and cervical length, a lot of focus came. In addition to the mother, you screened a lot of things in the fetus. The first trimester, why is it so important? Because it's a very important window of opportunity where you can not only do several important, investigations on the fetus, but it is a very crucial time to screen for maternal problems that happens in pregnancy. So this inversion of pyramid of antenatal care made the first trimester extremely important. We just heard about all this, and these are just visuals to support what we've heard, that in the first trimester, if you look at the fetus in a lot of detail, you can actually look at viability, size, structure, risk of aneuploidies, and risk of maternal complications. These structures, which you can see on the screen, even if many of you are not ultrasound specialists per se, you can identify the head of the baby, you can identify the formation of the face of the baby, the nasal bone, the spine, the umbilical cord, the four-chamber view of the heart, the kidneys of the baby. So a lot of fetal anatomy can be seen in a lot of detail as per the standard guidelines of the International Society for Ultrasound in Obstetrics and Gynecology, that you can actually make sure the baby does not have major abnormalities if you do a very detailed ultrasound in the first trimester, specifically the 11 to 14 week window, which serves as a major milestone for not only structural evaluation, but also risk factors of aneuploidies. Our first speaker was speaking about aneuploidy risks, and this measurement of fluid behind the neck, under the skin in the first trimester of pregnancy is what is the nuchal translucency. So all this can be seen in the first trimester. Similarly, assessment of the fetal face to look for, early signs of malformations of the face, midfacial hypoplasia, cleft lips or palate, or any of the major dysmorphic features can be seen. The spine can be evaluated such that major problems, which are often lethal and have a very, very poor quality of life, can be detected. And if the patients wish to discontinue pregnancies with major malformations, like you can see in the moving video, there is a huge mass coming out of the lower part of the spine of the baby. That is a large meningomyelocele, which we know eventually is not going to have a very good prognosis. And if this woman is a previous 2 or a previous 3 cesarean section, she would be benefit much more with an early pregnancy discontinuation than something which will pull on to second or third trimester. So these are the advantages of doing the first trimester screening. Similarly, looking at the fetal heart, detecting heart abnormalities, which are almost as traumatic as the CNS abnormalities and extremely common in the realm of congenital defects, can be done in the first trimester. The abdominal wall defects also can be seen in the first trimester, and decision making here will depend on associated problems, because sometimes the parents may want to continue, but if there is an associated chromosomal abnormality or genetic syndrome, then it becomes difficult. These are conditions where the fetal bladder looks large, either because of aneuploidies, which is like between 7 to 14 mm, you would suspect just hypotonia, aneuploidy related. If it's more than that, you would suspect lower urinary tract obstruction. And you have a picture here on the lower part of the screen on the left side, where the entire abdomen and even a part of the thorax actually seems to be compressed by a large bladder. And that is not a urinary tract obstruction, but an anterior wall muscle defect, which is part of a genetic condition known as the prune belly syndrome. And here the importance of diagnosing these things is that you may actually stump upon something which is a genetic syndrome, and the risk of recurrence is about 25%. So you just don't terminate the pregnancy and tell the patients that, okay, we have relieved you of one major abnormality, but you also alert them that there could be future problems, and then you work it up for the next pregnancy. Similarly, these are conditions where you have large polycystic kidneys, which are bilateral and presenting as early as 12 to 13 weeks of pregnancy. And we know that these are also part of an autosomal recessive genetic condition, and therefore not only it warrants termination in this pregnancy, but it also warrants prenatal diagnosis in the future, because the risk of recurrence is again 25%. Looking at fetal limbs is possible in the first trimester. Even if we can't make out, very, very subtle club foot or something like that, we can at least make out problems which are missing limb segments. And it is surprising to say that it is actually easier to see the limbs in the first trimester than in the second trimester. It is possible sometimes to get confused in second trimester when the hands are behind or in front, but it is much easier to see them in first trimester, and any missing limb segment can be picked up very easily in the first trimester. Huge abnormalities like this body wall complexes. And if you go through the literature, there are a certain number of abnormalities that have been categorically declared that these should be detected. We don't say must be detected because, there are limitations of screening all the time, but it should be detected in the first trimester because there is possibility of detection with standard machines and good level of skill that you can pick them up. And there are studies which have quoted almost 100% detection of certain issues in the first trimester. So when you do the first trimester scan, you can get a very good structural evaluation. And if you refine those points, like our first speaker said, there are markers, and they are maybe minor markers, but they have major importance in screening for chromosomal aneuploidies. So if you combine all these markers and put them along with the biochemical screening products like the free beta HCG and the pregnancy associated plasma protein A, you can get a sensitivity of almost 86 to 90% for the combined first trimester screening. And if you further refine it by using even better markers like the nasal bone, tricuspid regurgitation, ductus venosus, then you can get a sensitivity of almost 95% by just the scan and the blood test. So here you are anyway doing a detailed scanning to look at the structure of the baby. At the same time, you just refine it, use those as minor markers, and add 2 blood biochemistry products to it with the maternal age as the background. You get a sensitivity of 95% for screening for Down syndrome, which is a very good mark. Evaluation of multiple pregnancies. You know that the single most important factor in determining prognosis in multiple pregnancies is chorionicity. And establishment of chorionicity is done best in the first trimester. The differentiation between monochorionic and dichorionic twins will tell us what will be the risks of all the adverse pregnancy outcomes. And definitely monochorionics have a higher risk than dichorionics. So this classification and the early assessment of these complications can be done in the first trimester. So the first trimester scan becomes important for all these things as well. We just had this discussion on the cervical length, and I don't dispute the fact that you have to always use your clinical judgment, but there is a role of doing a cervical length assessment in the clinical assessment of preterm birth and risk of preterm labor, because sometimes it may be too late if you do not do it in the first trimester. So when you're anyway doing in a transvaginal scan to look at the anatomy of the baby, just measure the cervical length. Just measure the cervical length. And if you see obvious changes in the cervix, like there is an obvious funneling or there is very, very significant shortening, it may be useful to start acting at that point. How to intervene, what to intervene is very multifactorial. So there cannot be just one suggestion that, okay, if you see this, you do this. But whether you use cerclage, whether you use progesterone, whether you use a pessary, it will all be a part of the clinical, clinician's judgment, but there is a role of doing cervical length in the first trimester as a baseline assessment for the risk of preterm birth. And the Fetal Medicine Foundation calculator does give us the role for that. In the first trimester scan, there is also a role of doing maternal Dopplers, and the Dopplers that we do here are primarily the uterine artery Doppler. I am not talking about the ophthalmic artery Doppler right now because the evidence is still a little weak about it, and the measurement of the ophthalmic artery Doppler requires a specific linear probe, which some people may have or may not have while doing their obstetric scan assessment. So till it really becomes a clinically recommended practice, let's leave that there. Or the main Doppler that we do for the mother in the first trimester is the uterine artery Doppler. And this again is a part of this inverted pyramid where this assessment tells us the risk of preeclampsia in the mother, We've again heard another speaker talk about this and in a lot of detail again. So the remodeling that happens in the uterus at the time of the formation of the placenta is the reason why the uterine artery Doppler should show corroborative changes. So the uterus is a very dense muscle. It has living ligatures. It is a very, very thick muscular organ. When a placenta is formed inside, due to the invasion of the trophoblastic cells into the decidua, and the arboreal tree of the uterine artery from the arcuate, radial, basal, and spiral arterioles subsequently, there is an invasion of the muscular layer of the spiral arterioles by the trophoblastic tissue. And if this happens,
ಏನ್ ಗೊತ್ತಿಲ್ಲ ಲೈಟ್ ಇಲ್ಲಿ ಹೋಗ್ಯದ ಲೈಟ್ ಹಾಕ್ ನೋಡು ಮೇಲಿಂದ
sorry,
ಟಿವಿ
so
ಬರ್ತದೆ ಇದು
Sorry,
if
I'm
this
sorry,
happens,
sorry.
if this happens normally, then the resistance in the uteroplacental circulation decreases. When the resistance decreases, the vessel which flows into the uterus shows a good diastolic flow. So if you can see here, a non-pregnant uterus will have a natural impedance to the flow, whereas a pregnant uterus gradually through the trimesters will show a decreased impedance and an increased diastolic flow. And that is exactly what should happen in a well-growing pregnancy, in a pregnancy that doesn't show any signs of placental dysfunction. But if this dysfunction is there, then the impedance increases. However, it is possible to predict this by the Dopplers. When you look at the pathophysiology, obviously the predictive value will be better in the second trimester, because by second trimester, the placenta would have formed. And if still then the uterine arteries are abnormal, obviously this woman is at very high risk. But there is no benefit of intervening at that point. You can just say that, yes, it's going to rain very hard, but then you haven't brought your umbrella with you. So it would be better if you would know much earlier that it may rain hard and you would have an umbrella. At least if you don't have to use it, you still have the satisfaction of having it with you. But that is the advantage of doing this in the first trimester. Just like we were talking for the cervical length, there's no harm in measuring it. For cervical length, I still don't have a clear-cut answer about what you should do if it is short or what you should not do if it is short. But for uterine artery Dopplers, now we have evidence to say that if you find the Doppler is pretty high resistance in first trimester, which indicates a risk of preeclampsia, that too much better for early onset preeclampsia, then you can start the woman on 150 milligrams of aspirin, low dose aspirin at bedtime, and that will decrease the incidence of early onset preeclampsia. The calculators, which again my previous speakers have spoken, the calculators are given on the Fetal Medicine Foundation website, and they include maternal characteristics, they include biophysical characteristics, they include biochemical characteristics in addition to the ultrasound characteristics. And then, you have a risk of preeclampsia based on different parameters with a level of sensitivity. So if you find the risk of preeclampsia at any stage more than 1 in 100, you consider that as high risk. So that is the cutoff that you take. And if it is more than 1 in 100 for early onset preeclampsia, then the aspirin trial has proven that there is definite benefit of using low dose aspirin in early pregnancy. And once it is started, it is continued till 36 weeks of gestation, so that the beneficial effect continues. And here, if we did this in the first trimester, then only there is an advantage. Starting aspirin after 16 to 18 weeks of pregnancy does not show the benefit that it has if you started before 16 weeks of pregnancy. So the updated protocol for the first trimester screening would include everything. And the first part of this I have not discussed so far, but dating a pregnancy. Dating a pregnancy is one of the most important aspects. We started with the first trimester scan here, but again, the same CRL that is corroborated at the first trimester scan would also be useful if you had done it earlier on and confirmed that this pregnancy is of so and so weeks. Because later on, the problems with growth assessment come whenever there is a mistaken dates. So if there is a suspicion of growth restriction or macrosomia, one should not be confused about the dating of the pregnancy. And one of the important things to achieve in early pregnancy is the dating. Pre-screening test counseling, that is not an ultrasound-based or a very fancy intervention-based thing, but that is something which, as a clinician, one has to do. What I was discussing with my friend who presented the diabetes story that, unless you tell the patients that, look, you're pregnant and being pregnant puts you at risk of these things. And these are the problems that can happen. How Jyotika madam explained that, even if the woman can have a normal blood sugar, there might be because of already some dynamic changes happening in the diabetic scenario there. So you need to come and get yourself screened at this time. So one of the very important aspects of antenatal care in the early pregnancy would be to just give a complete trailer to the patient that, this is what is part of your pregnancy care. And these are the checkpoints where you need to come and get yourself tested. In India, there is this interesting phenomenon of people running away to different cities to do their jobs, to meet their mother-in-laws, and finally land up in the mother's place for delivery. And they will never carry their antenatal files with them. They will never carry whatever the doctor has told them. So it is important that at one place, you not only put them down, tell the lady that, keep this paper with you and show it to the next doctor that you see. That is the best antenatal care we can do for each other, that we write a note and give it to the next doctor that this is what I feel about this pregnancy, this is what I have written to this lady, and she should pay attention to this issue at this point in her antenatal care, and then she will also carry that there. So this pyramid of antenatal care helps us in triaging women to high risk or low risk. And when you begin well, you've almost done half of that work in the first trimester. And if you document all this well, the person who takes over care from you when she moves to another city to deliver because that's her mom's place or her aunt's place, then that doctor also has an advantage. So what all can we achieve in the first trimester? All this we have discussed and understood this in a lot of detail. The future applications of the first trimester screening protocols are coming up. There is further futuristic thought that you may have screening for preeclampsia separately and a screening for small for dates separately. You may use various biomarkers as have been written there. You may even screen for macrosomia, and you may screen for diabetes mellitus with other biochemical markers other than just our plain and simple blood sugars. So these are futuristic thoughts. They will come one day. This is something which has been brought up in one of the papers recently, that you have shifted from an inverted pyramid model to an arrow model for the screening of preeclampsia. Just like one of our speakers also spoke about, that there is a checkpoint for screening for preeclampsia at different stages. So yes, first trimester screening is very good because it helps you intervene and change the disease process. But everybody is not so lucky, and everybody may not respond that well to the intervention also. And there may be risk factors that may pop up later on. So checking again in the second trimester and again in the third trimester is important. What to check with is different, of course, but I will again and again reiterate that clinical testing is valid in all the trimesters. It may be a little difficult to establish the role of these expensive biomarkers at all levels, but looking at the blood pressure of a lady, looking at the change in the blood pressure pattern from the first trimester to the second trimester, and correlating it with the uterine artery Dopplers is really not difficult, because every baby will have a scan, so there will be a fetal scan. So just doing a uterine artery Doppler in the third trimester is not so difficult, even in cases of regular scans that we are doing. So doing a third trimester screening for preeclampsia converts this inverted pyramid into an arrow model. So then what is this extended inverted pyramid? Till now, whatever I was talking about was the inverted pyramid.
Yeah.
Just 2 minutes. So extended inverted pyramid is that to find better perinatal results, to better results in perinatal medicine, we start attacking the checkpoints at places where, even before the problem starts. So we start planning even before the placenta has formed, in periconception, preconception, and peri-implantation periods, and then make interventions so that the outcome of pregnancies will be good. So the scope of individual intervention starts from the preconception period and goes on to stages where it will prevent the placental dysfunction. So we come to the concept of what is called preconception care, and this is not a new concept. Preconception care is a very, very time-tested, integrated concept, which tells us that you look at the woman's health from her general health to all. We realize that preeclampsia can be a cause of, can be a result of maternal maladaptation to pregnancy because of pre-existing cardiac dysfunction. So doing a proper health checkup prior to pregnancy, doing certain tests like, the rubella, varicella, these are all part of the preconception test, but getting her health in order prior to pregnancy is going to help mitigate a lot of problems. So this is the checklist for preconception evaluation, which we would like to extend to all the students and the viewers who are watching, that make it a habit to look at everything before the conception starts, so that the overall perinatal results are useful. Preeclampsia screening, we've already seen this, but if a woman who has risk factors and then she's planning her pregnancy, whatever you can do to reduce the risk factors in the preconceptional period have to be done. All these medical disorders that we have seen should be addressed in the preconception period, so that they don't come into the antenatal forum without having them sorted out. Testing for gestational diabetes might be good, but having a woman conceive with a HbA1c of 10.4 and 11 is something we are seeing every day. And then if we start struggling with further screening and testing in pregnancy is not good practice. So having all these corrected in the preconception period would be good. New age problems, renal transplants, exposure to phytotoxic drugs and radiations, these are all part of the modern day problems. So all of us who are now handling patients in the antenatal care period should be liaising with people in other medical facilities and trying to get patients in the best possible medical condition to get pregnant. So this is a chapter which we have written on how to do preconception counseling in pre-existing medical conditions. And we have realized that just absence of evidence of benefit is not evidence of absence of benefit. So for all these conditions, doing an extended workup in the preconception period helps to identify this. And this is not a new concept. I just wanted to bring this up to say that this particular statement came from the 1800s, when they said physical treatment of children should begin as far as may be practicable with the earliest formation of the embryo, and therefore may necessarily involve the conduct of the mother even before her marriage as well as during her pregnancy. So preconception, premarital, adolescent health has an impact on future generations, and that is not an unknown problem. Same when you have patients who have had fetal losses and bad outcomes in the previous pregnancies. Don't wait for them to get pregnant when you start working again. People refer to us patients at 12 weeks or 18 weeks in the fetal medicine clinic when they've had bad outcomes in the past. We suggest they come to us before pregnancy so that there is an optimal preconception planning. So now, is this the pyramid of antenatal care? Many of you will say no, because I just showed you that the pyramid of antenatal care has become inverted. But is this the pyramid of antenatal care? I really ask you, is this the pyramid of antenatal care now? Anybody who's do you think this is yes or this is no? You know what? One thing which we are missing out, at the peril of taking another minute, I'm going to say, is none of them are the pyramids, because a pyramid is a three-dimensional structure. Just because we are drawing it with our two hands and writing that it is a pyramid, don't think that that itself is the pyramid. So pyramid of antenatal care has three dimensions, and therefore it has three faces to it. One face is that inverted triangle which we see always, and it talks about the investigations, the screenings, and the interventions. The other phase is what we can do whenever we see something wrong in the screening test. But that third phase is the history and clinical workup, which we are missing completely. We are missing completely asking patients what is their problem, what is their expectation of this pregnancy, what are the pre-existing problems, and what happened to them in the past pregnancy. So history taking is something very important. It's very sad that in the age of artificial intelligence, in the age of futuristic technology, we are pulling you back to very age-old practices. But believe me, ask the patient all her problems, and half of the time you will get the answers even before your investigations. So please take your history correctly. Whatever I'm telling you today will change tomorrow, because that's the law of medical science. What we learned earlier, it keeps changing. So keep updating yourself and practice in a way that you give your patient a holistic idea and do no harm while you are attending to patients. Sorry of exceeding the time. Thank you very much for this opportunity.
Thank you. Thank you, Dr. Chinmay. Ma'am, your comments, ma'am?
Very good talks, Chinmay. You covered almost everything. In the beginning, when you were talking about the inverted pyramid, I was wondering whether you were going to leave out the extended part. But then the extended part became a long extension by itself. But it was very good. Very nicely done. Thank you so much.
Thank you, ma'am. Thank you so much. I'm sorry I cannot get out of that inverted pyramid so easily because we are so stuck with that first trimester that we tend to prolong it. I'm sorry for exceeding the time. Thank you so much.
Very nicely done.
Sir, sorry we exceeded the time. Anything you want to add, sir?
No, nothing. Everything went on perfectly well. Of course, time was this thing. I'm very strict about it. Thank you very much. Extremely thankful to Dr. Chinmay.
I'm sorry for exceeding the time, sir. Next time I'll
It's all right.
not
Don't
get
be
carried
sorry.
away.
Don't be sorry.
No, no.
Hello. Hello,
Yeah.
Dr.
Hello,
Durgadas. Good
Shubham.
evening.
Yes.
Hi.
Yes.
Hi. Good evening. Good evening. I can see that you are on your way back to
Yeah.
Tumkur. Yeah.
What
Wishing you safe journey, Dr. Durgadas.
Thank you. Thank you.
And thank you once again, Dr. Durgadas, for conceptualizing this and putting the best people in charge. The think tanks in BSOG is Dr. Jyotika Desai, Dr. Sundari, and I think they would have done complete justice in assessing the speakers today. And of course, Srimati, your hard work you're such a gem for Bangalore society and for RCOG, what I believe. And we had another gem from Foxy today here with us, dear Chinmay. And I think she did wonderful justice to the subject. Thank you, Chinmay, for that wonderful talk. I think it was long awaited for KSOGA. And thank you very much, all the speakers, for doing this for KSOGA. Over to you, Dr. Durgadas. And if you want to conclude, let us look for Dr. Shobha Bembalgi. And I think
Shobha ma'am
Sundari
is
Madam's
not there,
comments
ma'am.
have not yet come. I feel that Dr. Sundari should speak. Her comments also, please. I didn't hear her, sorry. Maybe I did not log in between. I was traveling.
No, Shobha, it's a people of talk, no? See, I have done the questions I asked the students, but other things, everybody is doing it, no? So we were exceeding the time. That's why what? Anyway, Chinmay, congratulations. It was a wonderful talk, ma. It's too good.
Thank you so much,
And
ma'am.
I could feel your involvement in the talk. Okay.
Thank you, ma'am.
It was
Thank you so
very
much.
nice. Your experience and your knowledge and your involvement, we could feel it.
Thank you.
So thanks a lot. Very nice. We enjoyed it. Okay, though it has exceeded little time, but it was wonderful.
Thank you.
Thanks, everyone.
Ma'am, Shobha ma'am.
You can take over, Srimati.
No, ma'am, vote of thanks. I think Shobha ma'am is not able
You
to.
you can conclude, na, Srimati. You conclude today's program and you
Can I, ma'am?
deliver the vote of thanks.
Yeah.
Chinmay, I am really honored by your presence today.
Huh?
Chinmay, I am really honored. by
Chinmay,
your
yeah,
presence.
Chinmay, respond to
you.
Durgadas, sir. Yes.
Thank you
I'm
so
really
much.
honored
Thank
by
you.
your presence.
Not at
No,
all.
you
sir.
know, Chinmay, sometimes we feel embarrassed because you are younger to us. Then we think how to praise this girl. But then you do so well that we feel that you deserve it all out. Yes.
Very
So
kind
thanks
of
for
you.
being.
Thank you.
And
Srimati.
all the best for your new venture. Dr. Durgadas, she has started a very wonderful facility in Hyderabad. And if any of us wish to refer for fetal medicine, then I think one is, of course, Fernandez and the other one is Chinmay Ratha. We can say that.
No, ma'am, not so much.
So,
You're all welcome to
all
Hyderabad
the very
whenever.
best.
What is
All
that,
the very
Dr.
best,
Chinmay?
Chinmay. Yeah.
Dr.
Srimati,
Chinmay, what is that special one, what you have started?
Nothing,
Just
madam. We
in a
just take
sentence.
care
vote
of
of thanks,
patients.
really.
Let's.
Pardon?
Srimati, Dr.
Srimati.
Vote of thanks, yes, sir.
Vote of thanks,
Yeah.
please. Yeah.
Thank you, KSOGA. Thank the patrons. I thank the president for having initiated this webinar series. I thank Jyotika ma'am, who has been the backbone right from the day one, the conceptualizing and hand-holding and getting us through this webinar. And of course, all the judges, Jyotika ma'am, Sundari ma'am, Chinmay Ratha, And of course, all the speakers who did an excellent job, who were able to put up with my constant pestering. So I thank all the speakers who did a great job. Of course, Raju sir had expressed his apologies because he had to go for an emergency, so he couldn't join us. And of course, Dr. Chinmay Ratha for an excellent talk on extended inverted pyramid of care. So we're really very fortunate to have been able to do this.
Thank yourself.
Right. And I would have to thank Arun and the KSOGA office because he really put up with all our multiple corrections. And of course, all the audience who have joined us, all the delegates. So I thank everybody. Join us.
Coming out with the newsletter.
Speakers, yeah.
Yes,
Were
ma'am.
wonderful.
So
Their
the two
preparation was
things which I wanted to say. One is we are coming up with a newsletter after every webinar. So the 4 talks and the expert talk, we want to condense it and send it across to all KSOGIans. So before the next webinar series, this will be ready. And the second one is we are planning to do the next webinar, which is going to be on the 10th of June. So please watch the space. That is going to be on fertility or fertility trends. And we're going to have an expert talk on fertility preservation. So I hope to look all of you at the next webinar. So thank you very much.
Thank you, everybody. Thank you, Durgadas.
Thank you, Dr. Durgadas, Jyotika, Srimati for involving me. It was wonderful. Thank you very much, all of you.
Thank you. Thank you.
Thank you. Thank you.
Thank you, sir.
Durgadas, one suggestion. Next time, let them all send their presentations to Srimati. So
Yes,
that time is not wasted.
I will talk to Srimati. How can we more?
Yes, sorry, sir, we overran today.
You have done wonderful. You have done wonderful job. And guidance from Jyotika madam and Sundari madam. It's just a wonderful program. Always there are scope for corrections. You have done wonderful. Okay.
Thank you.
Thank you.
Very good. Chinmay, of course, I don't have to comment about it.
Thank you, sir. Thank you. Thank you, ma'am.
Thank you, everybody.
Thank you.